Welcome, everybody. It is so delightful to see so many of you, and actually, for so many of your names to be new. We're really excited that you're joining us today for this really important topic. I am Jennifer Pepper. I'm the Executive Director at Choices. I've been in this position a very long time, since January 1st of this year. And so I'm very excited to be here. One of the one of the best parts of my job is being able to support really important work that Choices is doing in the community. And one of those we're happy to talk to you about is the way Choices is improving and working to improve Black maternal health in Memphis. And so I want to start by recognizing that it's Black Maternal Health Week, and that this week of awareness and celebration was started by the Black Mamas Matter Alliance. And we are really excited to talk through what is a doula, what is a midwife, and what is OBGYN care. How do those things differ, and how do they intersect and overlap in order to provide the best kind of care for pregnant people? And so I'm going to take a little time. Oh, just to let you know, we are recording the session, and a recording of the session will be available on our YouTube channel shortly after we conclude today. So if you want to check it out again, you can go there. You can also go there to share it with some folks that weren't able to be with us today. So I feel most of you know, but just real quick for folks that may not, Choices is a nonprofit sexual and reproductive healthcare center in Memphis, Tennessee. We're actually the only nonprofit in the country right now that offers a full spectrum of sexual and reproductive healthcare. So Choices is proud to be able to care for folks for all of their sexual and reproductive health needs, and for pregnant people, regardless of the decision they wish to make about their pregnancy. Today, you are going to be talking to and hearing from some really amazing folks that are doing just phenomenal and very needed work in this space. The first is Dr. Nikia Grayson. She's a public health activist, an anthropologist, and a nurse who has devoted her life to serving and empowering people in underserved and marginalized communities. Nakia received her bachelor's in communications, one of her master's in public health from Howard University. She's earned a master's in medical anthropology, a master's in nursing, and finally a doctorate in nursing. Nakia has over 10 years of experience working in public health, reproductive justice, birth justice, and she currently serves as the Director of Clinical Services at Choices as an adjunct instructor at the University of Memphis. Miajenell Peake, since 2017, Peake Wellness was founded by Miajenell. She's been offering birth support in the greater Memphis and surrounding areas since then, providing services for over 60 women who have given birth. Affectionately known by her clients as Maya, this native Memphian has always been passionate about healthcare, specifically reproductive justice. Maya holds degrees in psychology, biology, and women's study from Georgia State University, and a master's in public health and health policy from Meharry Medical College. Maya is currently certified by the Doula Training and Certificate Organization, DONA International. Our third rock star that you'll be talking today is Dr. Pinckney. Dr. Pinckney is an OBGYN at Regional One Health. She earned her medical degree from the University of South Carolina in Charleston and completed her obstetrics and gynecological residency at the University of Tennessee Health Science Center. Dr. Pinckney says, "I became a physician because adequate health care is a necessity that many individuals don't have access to." Dr. Pinckney chose women's health as a particular field due to women being unique individuals with very different healthcare needs. And Dr. Pinckney believes that as physicians, if we are fortunate enough to share in huge milestones in patients' lives, and that is her favorite part of providing care. So thank you all so much for being with us today and sharing your general amazement and expertise with us. I want to start by asking each of you to introduce yourselves a little more. And I've got some kind of specific questions I'd like to ask each of you as part of your introduction. So Dr. Grayson, we'll begin with you. If you wouldn't mind starting by giving everybody an overview of your work at Choices.
Oh, wow. Okay, so good afternoon. Good morning for some if you're in the the West Coast. I'm Nikia Grayson, and I am the clinical director uh, here at Choices Memphis Center for Reproductive Health. Um, I've been with Choices now since June of 2017, and it's been an amazing ride. So, my work consists of providing wellness care, transgender care, as well as prenatal care for all of the people who come through our doors. And so, fortunately, we are a comprehensive reproductive healthcare center. Um, Really, is a very unique model where we are providing all the reproductive healthcare services under one roof. Fortunately for us, we also get to care for pregnant people who want to continue their pregnancies and want to birth with a midwife. And fortunately, I get to lead an amazing team of midwives here in Memphis, Tennessee. We have 4 midwives, and we provide all the care that happens in the building. So this is a midwifery-led practice, really encompassing the midwifery model of care and built on reproductive justice principles. So that's really important to us. We're also the first birth center here in Memphis, and we're really proud of that. So we offer out of hospital as well as hospital births, and we provide high quality, non-judgmental care here in the building.
Yeah, and so this next question, we could do a whole webinar on this, okay? So, but to give folks some grounding and context, give us the 30,000-foot view of history of midwifery, especially in the South, the Southern flavor.
Yeah, so the history of midwifery, really in the U.S. is um, not uh, it's not a new story, right? So midwives in the United States really, from the time of enslaved people all the way back to the colonies, provided the care for families in terms of birth support and prenatal care, and really, especially here in the South. African midwives uh, who were enslaved cared for families here, both black and white in the South. And midwifery was really prolific in the South and in our communities, where midwives not only provided care um, in terms of birth support, but they also provided abortion care. And um, so they were really seen as community helpers and healers. Um, Through politics and policies, and especially like the Shepherd-Towner Act, we saw an abolishment of midwifery, especially midwifery here in the South, and what we would categorize as a really detriment to our community was um, uh, really we lost the black midwives, which were the granny midwives or the grand midwives in our community. And in some states, like Georgia, they were like 4,000 black midwives, and now there are only a handful of midwives, black midwives in the South. So this, like I said, this history was really rich, and grand midwives were really seen as like these caregivers and healers and providers, um, and their abolishment, really hurt marginalized and poor communities, leaving them with really no access to prenatal care or even abortion care. And um, so there was this move to move birth out of the communities and out of the home to the hospital, and where really physicians became really interested in providing obstetric care. But now here in the 21st century, we're seeing a proliferation of midwifery again, and we're seeing this grassroots movement of people being interested in midwifery care, and interested in midwifery education. And so we're seeing a reestablishment of midwifery care in our communities, and that is really what we here at Choices are really working on.
The, your passion and desire to really create this pipeline for Black midwives is it's
Yeah,
going to be game changing for our community and for Black women everywhere.
right. One of the wonderful things about when I decided to become a midwife and really started working at Choices, one of the things that was really important to me was to create a pipeline and create a space for Black midwives to be able to train and really to work on the restoration of midwifery to the South. And so I think that we're doing that. And as evidenced by the care that we provide, the people that we see, but also the fact that we have hired two other Black midwives and really are about to start a training program for fellowship program for Black midwifery. So that's really important to me, and that's really important to our work here at Choices to make that impact and recognize the importance of, um, that culturally congruent care.
And correct me if I'm wrong, it's my understanding that there are 4 Black midwives in Memphis.
It is, yes, that's
And
correct, and
3 of
three of
them
them are
work
here.
for Choices.
Yes, we have them here, right here at Choices, and we're proud of that. We're proud of the work that we're doing to provide culturally congruent care.
So Dr. Grayson, talk to us about doulas and how, as a midwife, you work with doulas and how you work with them in our practice at Choices.
Yeah, doulas are such an important part of the care that we provide here, and it's such an important part of birth work. Um, Miajenell is an amazing doula who has worked with us and supported us and supported many of the families that we've cared for here. And, um, I'm biased. I would say I'm biased. I think she's probably the best doula in Memphis. And so she provides a lot of education and childbirth education and support that um, is so needed and necessary for the care that we're providing, right? So she acts as a tremendous partner with us in providing those wraparound services and that care. And she's an amazing labor coach. And we love having her in the building. We love having her at the births with us and partnering with her. But I would say that we work with pretty much all the doulas in the community. When I started, and I know when I will go back to say, my Janelle was also my first home birth. She was my first birth after I graduated. So, and she's still here, and her baby is safe. So, but one of the things which was interesting was when I decided to start working at Choices and became a midwife. There were only 2 Black doulas in the city, and Maya Janelle was one of them. And so she has worked really hard and tirelessly to also help to increase the number of Black doulas in this community, and we've worked really hard to support her in that. So she's provided training opportunities, she's provided training opportunities and just learning opportunities for other people who are interested in becoming doulas or just interested in birth work. Period. And so it's been really helpful to us and really helps us to be able to provide high quality care. I would say that doulas are so important to the community because they're also community health workers, right? So they provide a lot of education and support to their community, and it's really needed because a lot of times we can't be everywhere and we can't be everything, and so that doula partnership has been really amazing.
So, Nikia, I want you to talk, or Dr. Grayson, I'm sorry, I want you to talk a little bit more about something you and I have talked about, and I've heard you and Maya Janelle talk about. And Maya Janelle, please feel free to interject. What is the difference between a midwife and a doula? Like,
I'll let my Janelle tell you.
Well, I think it's a lot, like I think one of the biggest thing is doulas are not, they can't diagnose, they can't give medication. And, they're there for support. And every doula is different. I approach doula work in a more education perspective. I'm big on like making sure the person not only steps into birth knowing what to expect, but also share that information with her community. So, every doula is different, but I think the biggest thing is that doulas are not medical experts. Now they can assist with navigating the system, referring them to great physicians or midwives, but that's one of the biggest things. And I also like to say midwives are not doulas. You know, like 9 out of 10 times they're not going to talk all about all the things when it comes to the education around birth. They are medical professionals. So I think that's one of the biggest things.
Now, a lot of midwives did come to midwifery through being doulas, starting off as a doula, as labor support and childbirth education. I'm not a doula. I tell all my patients I'm not a doula. But I'm very supportive of doula work. Yeah.
And so, Miajenell, let's section into talking with you a little bit. Why don't you start by giving us an overview of Peake Wellness and what services you provide?
Yeah. I also like to just start with my work. I always been in like reproductive justice, reproductive health, but more on the HIV side, PEP and PrEP, and abortion access. But 4 years ago, I decided to, come to Memphis, and I got my start at Choices. And Rebecca Terrell at the time was the executive director. I didn't know anything about them opening up a birth center. I told her that I'm interested in maternal health. She told me to turn around, and I saw the blueprint of what Choices envisioned with this radical perspective of reproductive justice. And I was like, if I have to sweep floors, just sign me up. I want to do it. So with that time at Choices, I was able to learn about the intersections between abortion access and birth. And then I was pregnant. And Nikia was my midwife. I took a chance. She was a midwife. I was reading about midwives. She seems cool. And I was like, sure, let's do this. So with that superb level of care that I received at Choices, I really wanted women that looked like me to experience that level of care, right? So it wasn't, I didn't feel like a number. Nikia, we talked about everything in my life, even outside of, a diagnosis or like my health, right? And I was able to build a rapport. So overall, I just really wanted women to have the same kind of, pregnant people to have the same kind of level of care. So at Peake Wellness, my goal is to do that, right? So I want women, pregnant people, to go into birth, not fearing birth, being informed. I assist women, pregnant people with navigating the health system. 9 out of 10 times doulas know the community, right? So they know the prenatal chiropractor, they know the massage therapist, they know, the C-section rates at the hospitals, which is very important. We know doctors that are not so well, when it comes to like care. So I help them navigate the healthcare system. It can be very overwhelming, especially for new moms and parents. So again, we focus on prenatal education. Obviously, they're doing labor support, offer postpartum doula support, and placenta encapsulation.
Doing a lot of work. A lot that goes into supporting pregnant people. Talk to us about how you work with midwives, nurse midwives, and OBs like Dr. Pinckney in a hospital setting.
Yeah, I like to highlight that, every doula is different, and I think it's a lot of misconceptions around, doulas come in, what I like to say to Nikia, it's this misconception that we're going to come in with the stage, and wanting to burn down the whole healthcare system, burn it down. You can't trust the doula, you can't trust the doctors, you can't trust the midwives, blow it up, everybody approach birth differently, but, I don't think, at Peake Wellness, we do not. I like to stay in my lane. I'm always researching evidence-based information on how to approach birth. And I truly like working with reproductive justice healthcare providers. It's a difference. So, I'm at hospitals, I'm at Choices now, the birth center, and I'm at home. And, I just make sure that pregnant people are informed about what to expect. It doesn't matter what they want when it comes to their birth, whether it be unmedicated unmedicated vaginal birth, C-section. I feel like a doula is needed in all spaces.
How do the services you provide differ depending on where the birth is happening, in the hospital or at home or in the birth center?
Yeah, at Choices, I like to say I can let my hair down a little bit, knowing that the midwives there are excellent, brilliant. They're always researching what is the latest information on how to approach birth. I can't say that for other OBs or midwives in the city, not so much, So, I use a different side of my brain when I work at Choices. At hospitals, depending on the hospital, depending on the healthcare provider, I'm just making sure that the birth plan, has the best outcome. During COVID, things have changed, but yeah, you approach it a little different depending on what the patient or the client wants.
Thank you, Maya. Dr. Pinckney.
Hello.
Give us an overview of your OB practice.
Okay, first of all, hello everyone. I'm so glad that you all were able to join us today in this very important week. Like she mentioned, my name is Dr. Ashekia Pinckney. I currently work at Regional One Health as a academic generalist. So I am an obstetrician and gynecologist by training. At our practice, we have about 6 obstetricians and gynecologists that are responsible for labor and delivery. On labor and delivery, what we do is, of course, we do routine labor. We do any high-risk pregnancies and management of those conditions, such as patients with elevated blood pressures, preeclampsia, COVID patients, unfortunately. We also perform C-sections, so routine C-sections, emergency C-sections, and we also specialize in doing operative delivery. So I personally don't do forceps. I miss that era, but we do vacuum assisted delivery. So if you're in the process of laboring and you need a little bit extra help and you're closer to pushing, then we do vacuum assisted deliveries. Yeah.
Okay, great. And how often do you get the opportunity to work with doulas at the hospital, and what does that collaborative work look like?
Well, prior to COVID, Miajenell was one of the doulas that we worked with, and she's the only one that can stay in my mind because she does have a lot of our patients and takes great care of all of them. Currently, we're in the process of allowing doulas to come back to Regional One. We're working on that paperwork and making sure that everything is in place. What that work looks like is just like a partnership. Sometimes when our patients arrive, I don't necessarily have the relationship that the doula has with them, and it's more of a process for me to gain their trust, and so that they can not necessarily buy into the system, but so that I can be able to provide them with the best care. Having the doula there and me having a relationship with the doula can help me to get a better connection with the patient and educate the patient, as well as providing them with the autonomy to make the best decision for them.
And so then how do you and Dr. Grayson work together at the hospital? What does it look like when you're working with them?
Cats and dogs. No, no, Dr. Grayson, this is my world. Dr. Grayson was one of my nurses when I was a resident. So she is a part of my training process and me becoming the obstetrician that I am today. So it is a oiled machine. We definitely feed off of each other. With information, with ideas. My work with her has definitely changed my clinical practice a lot because of the time that she's able to spend with her patients. I definitely admire the relationship that she's able to develop with her patient, because a lot of time in the obstetrician office, you only have 15 to 20 minutes to see a patient. Like, your books are like this. And it has allowed me, by being around her, to say, okay, Pinky, slow down a little bit and, try to get to know this person, this individual. And that really helps me to individualize their care. And so working with Dr. Grayson and the other midwives, Talita, Kamitra, and Brooke, all of them, I'm like their phone a friend. So if there's anything that they need outside of their scope of practice, or if there's anything that we need to discuss, they just call me up and we work together to make sure the patient receives the care they need.
She's definitely our phone a friend.
Yeah, I love that description.
Yeah, and we phone her often. We love Ashekia Pinckney. She is a rock star, really. No, like she said, I got to know Dr. Pinckney when she was in her residency program, and I was really working on becoming a midwife. And so I feel like we kind of grew up together, right? And so she's amazing, and I have seen her grow, and her care has definitely expanded. But I will tell you that one of the amazing things about working with Pinckney is that it gives us credibility, right? Especially with our patients, to know that we have partnered with an amazing OB in the city, and they all, get to know her and love her as well. And she provides them with excellent care. And so while fortunately we do provide, continuity of care and our ability to be able to go into the hospital with our patients, if they need a C-section or if they need anything else, we are able to call Dr. Pinckney and consult with her, and they absolutely rave about her and the care that she's providing them. I have also seen Pinckney move from trying to cut folks. I'm like, Pinckney, don't cut them. Don't cut him, Dr. Pinckney, right? And so we laugh about that, but yeah, that's a really
that would mean a C-section, right? For
yes.
For gay people, I'm not violent.
right. No. But I think that the misconception is that midwives and OBs don't work together, and I think that one of the most amazing things about our relationship is that Pinckney comes over to the clinic often, and and we just sit down and talk about different topics and look at evidence-based care and figure out ways that we can improve as midwives, and she looks at ways that she can improve as an OB. And so that collaboration and that learning that we do together is really an important part of the practice that we have here.
So, and Dr. Grayson, so you are a certified nurse midwife, which means you can diagnose and prescribe medications and provide treatment.
Yes.
And Dr. Pinckney is a medical doctor, and she can diagnose things and prescribe treatments. And so how do your scopes differ? How do your scopes differ?
Yeah, I don't know, Pinckney, you want to answer that?
Sure. So I would say that I am more of the high risk patient population. So meaning that you have you have to deliver early, so you're preterm, or you have a comorbidity that requires you to definitely have an in-hospital birth and coordinate care with cardiologist or something like that. Also, if you require a C-section or any type of surgical procedure during your pregnancy, that'll be something that I would do, like an ectopic pregnancy or something like that. Or if you needed a tubal ligation after you deliver it, that would be something that I do. And I also perform, like I mentioned earlier, the operative delivery. So in case sometimes, if a patient is pushing with Dr. Grayson and we realize that she needs a little bit more help, then I would come in and place the vacuum assisted delivery in order to be able to deliver the patient vaginally. So yeah, I think that'll be the major difference.
Yeah, I think that what is really unique though is that by we have this Black doula, this Black OB, and this Black midwife, that we are really working hard to address the Black maternal health crisis that we're seeing right in this country. I mean, this crisis is not new. This is not something that happened overnight. Our system is inherently broken, and we do work together to try to address that. Maya, you want to talk about that a little bit, about what's going on in our healthcare system?
Yeah, and I just wanted to highlight that what makes Dr. Nikia Grayson and Dr. Pinckney different is they're the team of the willing to learn different ways to approach birth, and doing a lot of unlearning about some things that possibly they've been institutionalized to think about, like being patient. And I think that's one of the biggest things that makes them just amazing. So yeah, Black women are 4 times likely to die during childbirth compared to white women. Like Nikia said, this has been happening for years. You know, we recently started tracking this, probably in what, Nikia, like 10 years, you know, as far as like getting data to show that. But in our communities, we knew, you know, like we would have stories about like certain things happening. So these things have happened. So since I think 2017, it's been a national campaign to like really do things differently, you know, to support doula work, to support midwives, finding ways to promote the number of people that can get in when it comes to schools. So yeah, like it's a huge national event, you know, it's recent. Black Mamas Matter has done wonderful jobs in moving policy work. I also have been involved in like statewide pregnant workers acts with London Lamar and Senator Katrina Robinson. So yeah, you know, when it boils down to it, it's systematic racism. You know, when it comes to the health disparities that marginalized people experience. You know, so yeah. I'm grateful that Choices is doing a lot of work to have these conversations, you know, but again, like I feel like you have to be the group of the willing to learn these things, let the ego go, yeah, and try to approach things that are different.
Yeah.
I think, I'm sorry, Dr. Grayson,
No, Pinckney was about to say something, I think.
Oh, okay.
Oh, sorry, I didn't mean to interrupt. Like, yes, definitely what you said, Maya, about unlearning what you learned. You know, a lot of times in medical school, they would classify certain disease processes with African Americans or Hispanic Americans or white Americans. You know, those disease processes went with certain people. And what I like to say is that patients don't read the book. You know, like we get these clinical scenarios in a book, and this is how you're supposed to manage it. But a patient is an individual. And so you have to meet the patient where they are with their needs and with the symptoms that they're providing you, and listen and understand that patient. So a lot of times, of course, our patient population may not have the educational background to easily confer what's going on in their body. They just know something is wrong. So you have to listen to them when they're telling you something is wrong and really delve into what they're saying and meet them where they are.
Yeah.
I was always, when Maya mentioned the Black women are 4 times as likely to die in birth as white women and to have complications. And I'm always struck, and when I mention it to white people, they are often struck that that statistic holds true regardless of education or socioeconomic status.
Yep.
Right?
Yep.
Like,
Absolutely.
That is not a statistic of like marginalized
No.
people living in poverty. That is the Black female experience with birth.
That's the lawyer, that's the doctor, you know,
Right.
that's the woman that's married,
It's
you know.
Yeah, that's Serena Williams, right?
That's
Yeah.
Beyonce. Yeah.
Beyonce, yeah.
Right. I mean, a lot of it has to do with, you know, the stress of just being a Black woman in America, right? And so unfortunately, that stress coupled with the institutional and structural racism that we must experience just in our daily lives. I mean, you know, we read reports where, you know, interns reported that they thought that Black people's skin was thicker than white people's skin, or that their pain was not the same, that they did not experience pain in the same way. Or, you know, that we see, you know, institutions where people, and I'm just going to be very honest, learn on the poor and the marginalized, and then leave those spaces and go on to do other things. So, I mean, it's definitely a community that is seen as not important. And so the work that we do as providers and as birth workers, you know, is really important in terms of recognizing the humanity of all people and really listening to them and recognizing that they really are the expert of their bodies, and that we have a skill, but we don't know everything. And so partnering with our patients and really being able to provide them with information and empowerment. I think that what we're seeing now is, like, Dr. Pinckney said, they may not necessarily know what is wrong with them. We are seeing a different type of population now. Folks are coming in there with information. Okay, they are researching it themselves, and they are truly taking ownership of their bodies. They don't want to be treated like a number. They don't want to go to the hospital and be checked in and be told what is going to happen to them. They really want to be a part of their care. And I think that as providers, we are taught not to trust our patients. We're taught not to trust that they know what's happening with them, not to trust their historical memory. And this puts us on an uneven footing already. And so one of the things that's really important to me is taking that time and letting them know that I do trust you. I trust your judgment. I trust your ability to make the best decision for yourself in your life. And I have a skill, but I don't know everything. But together we can get through it.
And also recognizing that, yes, we know these statistics, but our patients know these statistics as well, that they're 4 times more likely. So they're scared. A lot of them are like frightened to even be pregnant in the first place, let alone to be in a hospital setting with people that they don't know. So being able to develop a relationship with a doula and a midwife and an obstetrician, and we all work together to rebuild their trust and all work together to listen to them, I think that's the way that we really can help to decrease the disparities that the African American are experiencing, is by doing an interdisciplinary approach, like everybody coming together to figure out what's going on with this patient. Things that Maya will get, things that Nakia will get, will be completely different from the information that I get throughout their history. But by all of us talking and communicating, Maya can tell Nakia what's going on, Nakia, so on. All of us can work together to be able to say, okay, well, something's not going right, and we need to get down to what's going on with this patient.
It's so funny because this is actually how it happens. There have been patients that, one of the wonderful things is that Dr. Pinckney will listen, and then they say, oh, I want to be with a midwife. I want to have an out-of-hospital birth experience. She will refer them to us and really work to support that. And I remember one instance, and she sent us someone, and after talking to them for an hour, I was like, Pinckney, did you know this? And she was like, what are you talking about? I've seen her for 3 months, and no, I didn't know any of those things. And I got all of those things in an hour and a half visit, and it's just it's a different way of providing care, but all parts of the team are important. And I think that, one of the things that I want to say also, because, that Dr. Pinckney said that patients come and that they're scared, and they really are. And one of the things that I think is really important, and especially about Black Maternal Health Week this year, this is the 4th year, and the theme is claiming our power, resilience, and liberation. I think one of the things that has happened is, we focus so much on the data that is scary, that we haven't focused enough on what we can do and the positive things that are coming out of the community. We do have the power to take this community by storm and really change the way healthcare is being delivered and really change the outcomes. And so I think, especially for me, especially for the midwives at Choices, and I know for Dr. Pinckney and also for Miajenell, we really do focus on what we can do to make things better and focus on empowerment versus focusing on these statistics that are really scary to people, right? And I think that that's the most important thing, because, for so long, I know Dr. Pinckney and Miajenell will agree, especially in our education, everything was like, oh, African-American communities experience this, African-American communities experience this. If the white community has a cold, then the African-American community has the flu. And, and it was always looked at from that perspective as if it was really about race. And it wasn't about race. It was about access. It was about the way that the system has been treating people, right? This unequal, unequitable system. And so how do we change that? And the ways we change that is being disruptors and reimagining how it can be. And so I see the partnership with Pinckney and with Maya as ways that we can reimagine how healthcare can be. And so we don't really look for, we, a lot of times, oh, they don't have money, or oh, they, people come into care and they're like, oh, well, they can't afford this. We are always looking for ways to provide a solution. And that's really important.
Yeah, I like to say, like, I'm a professional agitator. Like, you just can't tell me the sky's, orange when I know it's blue, But I think that it's very important to really highlight that the medical institution, like all other institutions in America in the Western Hemisphere, is embedded in eugenics, So we really have to have a conversation about that. Like Dr. Grayson, Dr. Pinckney said, it has nothing to do with race. It has something to do with systematic racism. And it's a lot of unlearning that we have to do when it comes to approaching people that look different. Their bodies are not diseased. It's really something that's going on in the environment that's making them sick. People don't come out normally sick. It's the environment. So definitely need to have a conversation. And I think, and I'm going to misquote Dr. Joya Perry, but she said something a couple of weeks ago around if you wanted to pick a profession that you could abuse Black people, choose a police officer or a doctor, and people wouldn't say anything. So it is this intersectionality that we need to talk about, how we approach people. So it's not in siloed, healthcare is not siloed.
No, and Maya, just I'm so glad that you guys are even allowing me to be in this. Awesome. Thank you so much. Maya, you said one of the things that you do as a doula is help women not or manage that fear around birth, especially in the hospital. What are some of the ways that you do that as a doula?
Yeah, I mean, it definitely has changed because of COVID. I'm not able to like go out and build that rapport. Like I like to say, like, I've become like a birth best friend to some extent. I want them to call me and, I'm always checking on them because I am getting a lot of information about them that's outside of their health. If they're suffering from homelessness, I need to know that information on how to like connect them with people that approach them a little different when it comes to that. So, I'm doing virtual support. We talk about all the medical interventions that could possibly happen. Even if they want an unmedicated vaginal birth, I want them to have working knowledge of a C-section, what that looks like, who's in that room, what medication would be administered, because again, I think media has done a wonderful job in scaring the hell out of people around birth, if you look at any TV show, you see a pregnant woman pulling her hair, just wilding out, which I like to say, like, most of my clients don't do that because if you're yelling, you're not breathing. Mm-hmm. So yeah, we do a lot of like new teaching on how to approach birth, and rightly so. A lot of Black people fear birth. They've been around their aunties and they've heard about hysterectomies they woke up and, they don't have a uterus. Like those are things that I'm not making up. These things have happened to Black people. So those stories are there. So with my support, I try my best to inform them about what to expect. And again, like I think the biggest thing is helping them find a good provider that they trust. I know my limitations, sometimes medicine is needed, and I want them to understand that. But sometimes it's, abused. So we talk about all that.
All right, so I'm gonna ask y'all to give us some tea and some gossip, okay? So it is clear that the three of you work together very well as a team and have lots of experience together. What is it really like in hospitals when midwives come in or when doulas come in? Dr. Peake, what does your profession, where does it sit in general around midwifery? Tell us.
Okay.
Tell
Yeah.
us.
We're gonna
The
let
real. Yeah, so I'll give you the real. So a lot of times, you know, in medicine, anytime that there is someone that practices differently than you, then we become intimidated and aggressive, and we put down the other profession, right? Which is completely inaccurate, because like we mentioned, everybody provides a different scope of practice, which all goes together to help the patient get the care that they need. So yes, sometimes physicians, because they don't understand what a doula is or what a midwife is, they'll put down their profession and try to make it as though the doctor is the only way to go, because this is what they know. And just like Maya was saying, like, you really have to change people's um, brainwashing that had happened in medical school and say, hey, there are different professions out there that can provide adequate care to these individuals, and we all have the same goal of having a healthy mom and a healthy baby. So that is my job here as a liaison between Choices and Regional 1, is to really just sit there and say, this is what they do, and this is what I do as an obstetrician, and these are our roles. And just being a person to communicate with them that it's okay that she wants her to bounce on a peanut ball or to walk around and breathe. That's what she wants to do. She wants to stand up and squat. That's within her right. And this person is here that can help her with that. And if you sit back, you may learn something, you know? So that's my thought.
Yeah, I think that, you know, I think what I have learned is that it's different regionally also, right? In some areas in the country, midwives are more integrated into the midwives and doulas, really just birth workers in general, even lactation counselors are better integrated into the community, the medical community there. And in those communities, we know because Dr. Sears Swati Vidam, she has a group called the Birth Lab, and she's actually mapped the United States and all the 50 states.
Wow.
And what she's shown is that in communities where midwives are more integrated into the medical community, there have been better birth outcomes. And so we see this is regional. Some regions have a better integration of midwives into the community and better integration of doulas into the community. And then you have those that don't. And unfortunately, the South, like with everything else, does not have that integration. And so what we're seeing is a pushback a lot of times when we do take patients to the hospital. And this can really affect birth outcomes because, you know, people are choosing to have a home birth or have a midwife that is not affiliated with that hospital or don't have privileges at that hospital. They may wait longer to transfer because of the reception that they may receive.
Or or if they didn't have a good outcome, like a good welcome when they came, then they're like, oh, well, we'll figure it out, you know. So they may push their care off, like you said, if a nurse like downplayed them, or if they knew a physician said something about their practice. Like, it's just not fair.
Yeah, and you know, and unfortunately, in the beginning, when I first started practicing, that was the reception. Midwives were not welcomed in the community. And in a lot of ways, we still are not, in the medical community. But fortunately, we have developed some amazing partnerships that is really changing that and really changing how we are seen in the community. Because one of the things I will say is midwives are here to stay. We're not going anywhere. We are going to grow in numbers and really provide the care that people want to see in their communities. But definitely, it was a rocky start. I will say, like I said, there were a handful of OBs that have always been very supportive of me personally and the work that I've been doing, and for that reason, it made it a little bit better. But it is very hard. It's hard when you have patients to come and they say, my OB or my physician told me that you were unskilled or you were untrained, or I've had a patient's mother call me a witch, and that what I was doing was witchcraft. I mean, it's just really strange. I'm like, oh wow, really? Okay. And so But I think that the way you overcome that is keep your head down, do the work, and the work starts to speak for itself. And so fortunately, I can say that has been my experience. Now, I'm not sure about Miajenell in the hospital.
Yeah, tell us, Maya.
I mean, on the totem pole of power, doulas are, down there, but and that's why I put emphasis on really finding a reproductive justice provider. I approach work a little different when I get to work with, I know people that have done the work, that's not just going through the motions and looking at patients as numbers. At the hospital, it depends on the provider. And sometimes not even the provider, because, the OB doesn't spend a lot of time in labor with the patient. It's the nurses sometimes that you really have the conflict with. So with my patients, because of COVID, I used to try to go to the prenatal appointments, inform the provider that she has a doula or they have a doula before. But again, it just really depends. But I like to say that the work that Choices is doing is getting around the other hospitals. So when I 4 years ago, it wasn't only Regional 1 had coreless monitors. And I think at the time they had 1 or 2. Now, other hospitals are peanut balls, yoga balls, all these things. So you all being the agitators in the community, it is speaking. I think, 4 years ago, it was only 2 doulas. Now we have a plethora of doulas. But I also would like to see more policy work. I do think, increasing the number of doulas is very important. Increasing the number of midwives is important. But we also have to change systematic policies that are in hospitals as well.
Thank you all for your honesty. I want to talk about a little bit, and we'll open questions up to the audience shortly. So for our attendees, if you guys have questions, please feel free to put them in the chat box for us. But I would like each of you to talk about kind of the pathway to your profession. How do you become a doula? How do you become a midwife? And Nikia, if you could talk about the different kinds of midwives. And then how do you become an OBGYN? Because it's been clear through just the last hour with you guys that they're all essential and critical roles in providing these holistic birth experiences. So Maya, let's start with you. How would somebody become a doula if they wanted to become a doula?
Yeah, it's different ways. I like to say, just if you have somebody in your community, and they're pregnant, try to offer them some support, read some books, around maternal health in the US. I always start with Dorothy Roberts' books, Medical Apartheid, like all those books to increase like your intersectionality of maternal health. Start there. It's a lot of like DONA, doula certifications out there. Everyone approach doula work differently. You don't necessarily have to be credentialed to start. I like to say that you can just start helping people. I think that's one of the biggest things is we really just need boots on the ground at this point. Certification will come in later. Now because of COVID, it is restrictions on doulas that are not certified. Out of 4 of the hospitals, DONA certified doulas are able to attend births. I know Regional 1 is working on their policy when it comes to letting doulas in. But, I just say, just start, you're not going to know everything, and I think that's important just to start and learn as you go. Every client, every patient, everybody is different, so just start.
Yeah, Maya, you were the only doula I knew for a long time. And so when other people show up and introduce themselves as doulas, I'm like, but you're not Miajenell. Dr. Grayson, what are the 2 different kinds of midwives and what are those career paths?
Yeah, so there are different types of midwives. There are certified nurse midwives, there are certified professional midwives, and some are considered direct entry midwives. You said what? Yeah, some are direct entry midwives. Each state has different laws around licensed in midwives. Nurse midwives are licensed in all 50 states. Certified professional midwives are not licensed in all 50 states. We border Mississippi, and of course, certified nurse midwives can practice in Mississippi, but they don't have certified professional midwives there. So midwifery is illegal there. I mean, it just doesn't have any laws around it. There are different pathways in terms of education. There are didactic programs for people who just want to be a midwife. And they're growing in numbers. I'm a nurse midwife, so I went to nursing school first, and then have an advanced practice nursing license in midwifery and family nurse practitioner. So there are different pathways. I have also a doctorate in nursing. So so nurse midwives have to get an advanced degree, graduate degree. That's the word I was looking for, graduate degree. And we are advanced practice nurses. The education takes a little bit longer because it could take you for anywhere from, if you already have a bachelor's in nursing, then it's a 2 or 3 year program, depending if you get a master's or a doctorate in nursing. But nurse midwives can practice in hospital and out of hospital, whereas certified professional midwives only practice out of hospital. So the pathways are different, but also, I would say certified professional midwives they're like specialists in home birth and out of hospital birth. And so I think that's the difference, because a lot of nurse midwives are not trained in out of hospital birth, and they're definitely not trained in home birth. And so that was a really big leap for me, because I was trained in a hospital as a nurse and as a nurse midwife. And when I decided to start practicing, and Choices is the only place I've practiced as a midwife, I did home birth first, because there was no pathway for me to practice in the hospital. So we are seeing changes in that. Like I said, in other states, some midwives can practice independently. They don't have to have that collaborative practice with a physician. So each state has its own, own rules, basically.
And in addition to the nurse midwives choices employees, we also employ a certified professional midwife who really brings, like you said, that expertise.
Oh, yeah, she's wonderful. She's amazing. She's been a certified, she's a certified professional midwife and has been doing midwifery for over 8 years. And she just brings a totally different perspective. And she really has helped to round out our clinic and our care. And really, when I started practicing, she was a great resource for me and really would help me in our out of hospital births, because we're not trained to do out of hospital births. So Brooke was an amazing help to me and really to our community. She really is an asset.
Absolutely. Nikia, Dr. Grayson, please, there's a question from the chat.
Okay.
Any advice for future CPMs, professional midwives?
Yeah, I would say that one of the great things is Tennessee does license CPMs. I think that really partnering with midwives, nurse midwives, really working together in the community, because we need each other, right? It's not a lot of us, but there are some great didactic programs for CPMs. I know Midwives College of Utah has one. Bastyr has a program. There are many amazing programs out there where you can get that didactic learning and really become an asset to your community. We're really trying to grow all midwives, not just nurse midwives. And that's one of the great things about Choices. Also, we do train or provide training opportunity for all midwives, not just nurse midwives.
Thanks, Dr. Grayson. Dr. Pinckney, how does somebody become an obstetrician if they would like to follow that career path?
Yeah, so to become an obstetrician gynecologist, you start off with a bachelor's degree. Usually in your bachelor's degree, you complete your prerequisites for medical school, which are a variety of science classes. And then you will get accepted into a medical school. Medical school is usually about 4 years long. After medical school, you are a doctor, but then you have to go through your training, which is called residency. So just like most jobs, you go train for like a month or 6 months, and then you can practice. Our residency is 4 years, and that's if you're just going to be an obstetrician gynecologist and you're not specializing in anything else. And so during your residency training, you start off and slowly advance over the years, and you graduate and you're an obstetrician gynecologist.
It's just that easy.
It's just that easy. 12 years of your life. What is that? I mean,
Right. And Maya said, and to become an RJ birth worker, erase everything you have learned. Absolutely. Everything except for the skill, and erase everything else, right? And that's real. I mean, I feel like we had to, I think that for me, it was different because I came into this work really from a social justice perspective and decided that I wanted to be a nurse midwife to fill this gap, and really was already rooted in this reproductive justice model, right? So it was easy for me to go to nursing school. Well, I won't say easy, because nursing school was very harmful. I was like, that's not true. That's not true either. And so, pushing back against that and pushing back against that system as an only can be very hard. But I think that I was fortunate that I didn't have to decolonize myself and rebuild myself up in that, because I had that background already. I had already done, women's studies and all of those things. And really, I come from a Black feminist perspective, and I embrace that, and I stand in that, and I'm very, sure about what I know in terms of how to care for and how to partner with our community, right? And recognizing that they are valuable, and to recognize their humanity. And so that's really hard for a lot of people who are trained through a medical model, where we see people as a body and as a disease state, and to move from that to really recognize, like I said, their humanity, and treat them with dignity, for some can be very hard.
I think it was easy for me to become a reproductive justice worker because that's me. Like, I'm the one that's dying. I am an obstetrician and gynecologist, and I can go into a hospital right now, and I'm 4 times more likely to die than anyone else. And so it was easy for me to buy into it, because it's like, it's me that's dying. I also attended Spelman College. So it's like, all of my other, colleagues and the people I graduated with, we're the ones that's dying. So having to get a better understanding of the reason why and facing those social injustices is definitely a passion of mine. I'm also the assistant program director of the residency program here. So I'm constantly trying to get, speak to my residents and break into their mind that this is a patient, this is an individual. She did not read the book. This is not evidence-based medicine. This is clinical medicine. So there's a difference, You can't sit there and say, well, evidence says blah, blah, whatever. Like, this is the individual, and you need to treat her as who she is,
Yeah.
Just take a moment to be thankful and recognize the contributions HBCUs have made to the world.
I know, right?
So much.
Yes, absolutely.
Dr. Grayson, or maybe Miajenell might know, are there any direct entry programs for midwifery in the state of Tennessee? And I'm going to admit, I don't know what a direct entry program for midwifery is. So if you could tell us what it is a little bit, and then if there are any.
There aren't any in Tennessee.
Okay.
So like a direct entry program would be like that program I said, like Midwives College in Utah. Jenny Joseph has a direct entry school in Florida. Is it Common Sense? Is that Jenny's school? Common Sense, I think childbirth, where she has a part where she does education, but then she has a part where she trains midwives. And so we don't have any of those here in Tennessee. Now there are training places like the Farm, which is out in Summertown. They do provide education and training for like birth assistants, and they do some midwifery classes and things like that. But there is no didactic school here. No. Mm-hmm. Somebody asked.
Yeah, we have a question. We want to know, folks want to know, what is the most rewarding part of the work you do, and what's the most challenging part of the work you do? Miajenell, you want to kick us off?
Yeah, I normally talk to Nakia every day, but sometimes I call her crying. I'm like, this just happened, Especially now that I'm going to nursing school. Yeah, I call Nikia very frequently to cry and tell her what's going on. But to answer the question, I'm sorry, what was the question?
What's the best part and what's the hardest?
Oh, yeah. I mean, it's a lot of great parts, like really just seeing that one person was fearful in the beginning, didn't know what to expect, had all these misconceptions about birth, and she became a mom, or they became a parent. I think that's one of the biggest things, just seeing that transition of like them stepping into their them making informed decisions, and sometimes like them being a part of like the process of birth and knowing about it a little bit more, it kind of spearheads other things. They're like, okay, I can do other things now, like I can start a business, I can, go back to school, like I think that's one of the biggest blessing of doing this work, like just seeing the transition and them stepping into their power, that's one of the biggest. Now, the hardest thing, I like to say this is heart work. It takes a lot of you, it's emotionally draining, especially now in, COVID, if Black women were 4 times likely to die, before COVID, let's see the stats now, so sometimes it's very hard when, as a doula, another way to approach birth. But sometimes you don't have the last say, that's why I don't necessarily like going to hospitals. My clients need me, I'm there, but sometimes it can be very challenging because you don't have the credentials, to say, just turn her on her side instead of just calling a C-section after, an hour for pushing. You have the evidence, you have the history behind what is possible, but sometimes the provider has the last say.
Dr. Pinckney, what's the best and the most challenging part of your work?
Like my niece said, is working nights. She's 6 years old, and she was like, I don't want to be a doctor, I don't want to work nights. Like, oh, you already know. But no, so I would say the most challenging part is that showing up for your patient no matter what you're going through. You know what I'm saying? Because it's always as if like, yeah, I can be having a hard day. I can be having, I'm tired, I'm hungry, whatever. But this is her unique experience. Like, she's having a baby, this is something that's going to be ingrained. This is just another day for me. Yes, I'm tired, I'm hungry, but really showing up for your patients and putting your own needs to the side. So really having to be selfless while we're here, and you're constantly giving of yourself to others. And sometimes the things that your patients are going through, you can't necessarily help them with. And that's emotionally draining, because you're trying to show up for them. You're trying to be understanding for them. But no, I've never been in this particular situation. No, I've never been homeless. No, I've never had a family that didn't support me and didn't want to support my pregnancy. But I have to sit there and empathize with that patient. And sometimes you take that home. Like, man, that's hard. Like, I hope she's okay, or I hope everything gets better for her. And so it just really, like she said, it's hard work. And it just really, a 12-hour shift can feel like 3 days, just how much emotional investment you have to give to your patient.
Dr. Grayson?
Yeah, that's a good question. I think that when I decided to be a midwife, I really thought I was going to be just providing care for people, but I am a social worker. Like Dr. Pinckney said, we see patients who are experiencing housing insecurity and food insecurity and job insecurity and just domestic violence and all these things, and really trying to figure out ways to help them to navigate those things. I mean, I'm a solution-oriented person, so it's really important for me to help people to find solutions, to put things in place for them so that they can thrive. And so that can be very hard. Sometimes I think that that's one of the things I think that Maya and I talk about a lot in terms of, because we do share the same patients, we have to find patients jobs and and finding them housing and finding them a place to have an out of hospital birth. And the last one was going to be at Maya's house. It was like, listen,
we gotta do what we gotta do,
come birth at your house. And she was like, okay, let me talk to my husband about it.
And he okayed it. So.
Right. So, that can be very challenging, but I will say that the work is so extremely rewarding. It is so amazing to be a part of people's lives and stories in this way. And you really do gain a community. That was one of the things I have seen at Choices is that we have grown a community. And so I know all of these little babies and I see them out in the community and their parents send me pictures of them and they call me and they check on me and they're like, I know you're not eating. I know you've been up all night. I know you. So, we do, that's really rewarding to be able to create community with people and know that you've impacted their life. And so while the work is very challenging, and Miajenell does call me and cry, and what do I say? I was like, listen, okay, you can cry for 5 minutes. Okay, come on, we got to go. We got to get this work done. And we've been on our way to a birth, and she's crying in the passenger seat, and I'm like, okay, you got to pull yourself together because we got to go in here now. So, but yeah, so it's been really wonderful to really, like I said, create what you want to see in the world. So I really enjoyed that part of my work.
A question from the audience. And either any of you can answer, but what information or kind of screenings or things to think about do you tell people or talk to people about when they're considering an out of hospital birth, whether that's at home or in a birth center? Is that the right choice for all pregnant people? Talk to us about that.
I would say that to make sure that you don't have a comorbidity that will require you to need a higher level of care. So that means to make sure that you don't have uncontrolled blood pressure that you would need IV medication. Make sure that your blood level isn't too low that you may need a blood transfusion or something like that. So my thing is like, I'm scared to death of a home birth. There's not enough anxiolytics in the world for me to even show up to one. But just because I'm very hands-on, so I need to see what this is and I need to be able to cut when I need to. So that's just my own anxiety. But I definitely feel as if you do desire home birth, that is within your right. This is your birth experience. This is your baby. This is your life. But you definitely have to consider the other medical problems that you may have that will put you at risk of having a poor outcome by delivering at home.
And I would also like to say, like, once the provider, Nikia, or OB or midwife clears you, it's more like a mental game at that point, So, yeah, we don't want fear to show up. So when my clients tell me they're having a home birth, I'm definitely checking in a little bit more, making sure that they are informed about all the things because they don't have any medicine that they can rely on as far as like pain relief, medication rather. So we talk about, therapeutic ways to reduce pain a little bit more. But, if you're cleared to have a home birth, I like to say it's probably like 60% mental at that point, because you are low risk, and that 40% is probably physical.
Yeah, I think at this point, for me, low risk is relative, right? I think that, we have to also recognize that unfortunately, in Memphis, the population is sick. We care for a very sick population. Now, pregnancy is not pathological. Pregnancy is definitely something that's physiological and normal and does not in itself need to be managed or intervened on, right? But then we always have these other things that can affect our pregnancy. And we really do need to manage those other things. And so what we end up seeing is that people who should probably sometimes be in the hospital, not wanting to be there. So really that's where that collaboration comes in. And I will say that Dr. Pinckney has been wonderful in collaborating with us, but also Dr. Tate, who is our maternal fetal medicine doctor. And we call Dr. Tate all the time. She always answers the phone, and we're so appreciative to her for that. But sometimes people need another level of care than we can provide. And that's real. And so we know what our scope of practice is, and we know how to collaborate. And what makes it easy to do that is having those physicians in the community that are willing to collaborate. I want to also say that Dr. Pinckney has agreed to, when she get pregnant, to have a out of hospital birth.
And I was gonna say the same thing. I don't care what she say. I'm gonna be there.
Right, right. She's going to have an out of hospital birth, and we are going to take really good care of her and here at the birth center. So we're going to see how that goes.
Super excited to welcoming baby Pinckney with into the birth center. Maya, this question is for you. Do you have any advice for people wanting to become full scope doulas or abortion doulas? Where would you point them for training or resources?
Yeah, it really depends on where they are. Locally, I would like to, you can always go to your independent abortion clinic and follow up with them to see if they have any availability or if that's a way for you to learn more about being abortion doula. I know Planned Parenthood sometimes have, they have like trainings and stuff like that. But it's no real like national, organization that is leading that pathway, but you can always start small and contact your local independent abortion clinic. If you're in Memphis, the only one is Choices.
Yeah, I love that question, and thanks for asking, because it's really about whatever option you choose for your pregnancy, right? Midwives can help you through that. Obviously, OBGYNs can help you with that. And doulas also can support women, whether it's pregnancy or abortion. And that's the RJ model too, right? Like,
yeah, and I think that, yeah, and I think that we kind of like separate them, but historically, midwives have done both, so yeah, if you want to really support people, you have to be comfortable with their choice and lead them in the pathway that helps them with their decision.
Yeah, I think that non-judgmental care is really important, right? And like I said, historically, midwives were the ones that people sought out if they wanted to continue their pregnancy or not continue this pregnancy. And even now in the United States, in some states, midwives do still provide both of those services. Not here in Tennessee, but in other states they do.
Yeah. Uh, so this is a great question, and I feel certain you guys all have some thoughts on this. What are the best ways that medical institutions, so training programs, hospitals, can really either help people unlearn all the nonsense they need to unlearn, and then help mold our future clinicians in kind of this RJ way of looking at people?
Yeah, that's a really good question. Actually, we're working on something like that now. Um, I think part of it is education. We have to really look at the model and how they've been educated and what they're being taught, and also who they're being taught by, right? So, um, what type of training is the attending modeling for them? I think those things are really important. But part of it is really looking at the curriculum, the didactic curriculum, and seeing where harm is being reproduced, and really eliminating those things. We talk about now we have all of these trainings around implicit bias and anti-racist training, and I think that we have to get that into the curriculum and into the schools, because once they've graduated, it's really harder to overcome that without people really having that desire to do so. I think that's one of the things that I've seen with some OBs. They have the desire to provide care in a different way, and so they work hard on re-educating themselves. But I think also we need to do a better job of screening students that are coming in, because I know a few of students that I have in undergrad that tell me that they want to be medical providers, and I already told them you should not be a medical provider. Okay, so it's just real talk, and so we have to really do a better job of screening those um, who are not good candidates for providing care for all communities. So, like I said, we are working, Choices and some other OBs are working together on a project to kind of really start at that training level.
And like I mentioned previously, in in medicine, it's all about the evidence. So what does the evidence say? And is it safe? Is it this? Is it that? And again, patients don't read the book, you know? So I tell my residents constantly, there's something called clinical medicine. So what is your clinical common sense, and how can you apply that to this patient so that she can have the experience that she desires and you can keep her safe in the process? And so I think that having the residents just open their mind outside of what they're taught in the book and developing their own clinical common sense to say, hey, yeah, it may be okay for her to stand up and push if I put this rail here and I put this here, and someone, you know, we just have to step out of the box. Like Miajenell said, be an agitator, a chronic agitator, to say like this, yeah, this is the system, but it doesn't have to be this way. We can do this safely and have a safe delivery.
Yeah, I think I also look at like future, you know, like it's so many barriers on a lot of like brown, Black people trying to, you know, wanting to be a provider, but can't, you know? So I think that we just need more, you know. All three of us came from HBCU. So, you know, it just speaks volumes about, you know, we know how to take care of our own, you know. So we need more people that look like us to be in those positions. You know, and all skin folks ain't kin folks, you know. I like to say that, you know.
Yeah.
Yes. But I think that's like one step. It's the bottom, it's not the top of the work, you know.
Yeah, absolutely. I mean, our culturally congruent care is important. That really, that decolonizing medical education and institutions is really the most important thing that we can do at this point. And fortunately, you know, that work is being done. It's just, you know, being done really slowly. We need more hands on deck. Like Maya said, we don't make up the majority. I think for Black OBs, what is the number, Dr. Pinckney?
4%.
Okay, so Black OBs make up about 4%. Black midwives make up about 3% of all the midwives in the country, and so that's not a lot. I mean, especially in terms of midwifery, when we only have maybe 15 to 17,000 practicing midwives in the country. So that's a really small number, but we are mighty, and we are working really hard to bring about change. And I see someone ask in the chat, as a doula, how can you collaborate with Choices and Regional One with assisting in maternal health? I think that's a good question. I think one of the things is become involved in the work that we're doing, because of COVID has just made us have a new normal. And I think that one of the things that Choices is we find that we have to do all sorts of work in terms of policy work as well as really patient care. And so I would say definitely getting involved in that policy work that is happening. Like Janelle said, London Lamar and Katrina Robinson at the state are working really hard on pushing some legislation through that will advance doulas being able to be reimbursed and being recognized and practiced. Also, the Momnibus that is being presented by Representative Underwood. So we're talking about not just local policy, but also national policy work that's happening. Choices is really involved in that policy work part. That's really important because it affects us on so many different levels. But I think that's one of the ways to collaborate. I think also registering with Regional One to be a doula to provide care. I know Dr. Pinckney and some of them over there are really working hard to try to get doulas in the building and to partner with doulas to really bridge that gap between them and the community. So those are some ways.
I see we're wrap up, I also saw Dr. Grayson a few questions about preceptorship choices.
Yeah.
I would like to take this one. So
She doesn't like me to answer these questions.
I do not. So we do offer clinical training opportunities. There is a process that we ask folks to go through. That process is not to email Dr. Grayson. We try to be really mindful of protecting her time, resources, and her rest specifically. And so if you are interested in a clinical training opportunity with Choices, you are welcome to email me or our HR coordinator, and that information is on our website. And it's we take as many folks as we can. It's really about timing. There's only so many midwives and so many physicians, and so Dr. Grayson cannot walk around with 4 students behind her.
Right. I don't.
Who else is on the schedule?
Right.
But please call and beat her up if we can't take you.
I want to answer Chastity's question too.
Yeah, please.
About Hypno Babies program. That's really interesting that you asked that. Actually, what brought me into one of the first trainings that I ever took, and I was not trying to be a birth worker at that time. I only took the training because it was a doula training and I wanted to know more about birth work. It was actually a Hypno Babies training, and it was actually in California. I flew from here to California. It was a week-long training, and that was in 2007. And it was a great course, really, because it's really, of course, talking about self-hypnosis and using hypnosis as labor pain management. I have not seen that course outside of, certain spaces, and I have never seen it offered outside of California. There is, though, this one advanced practice nurse that I do know. He actually offers it. He is here in the building, Andre. He is our CRNA. He is trained as a Hypno Babies provider, and he and I have talked about it in the past, but we've never offered it as a training here. But he is the only person I know that's trained to do it. But there are no classes that I know of in Memphis. And I don't know what the reason is for it. It just hadn't caught on in this area, but he is the one who I know who also teaches it, because he asked me about it. And like I said, I did take the training back in 2007, and he and I have talked about offering it, but maybe we'll do that now that someone has asked about it. But I didn't know many other people knew about it. But yeah, it's just basically using hypnosis as labor pain management. But it is a great training, and that was the first childbirth education doula. It was a childbirth education doula training and a Hypno Babies training in California. It was a week long, and I stayed there, and it was wonderful. But I will say this, that I was the only Black person in class, and this was my first experience in really talking to people about their childbirth experiences. And this was the first time I had ever been with a group of people who talked positively about being pregnant and having these childbirth experiences. I had never seen that before in my life. And so it really made me want to do that for us, to have those positive childbirth experiences as well.
Any final words?
We can do this. We really can help to decrease these bad outcomes in the African American women population. We just have to, be agitators. Just, mess with the system, forget the system, burn it down, rebuild it.
Burn it down.
Yeah, and work together. Everybody plays a key role in being able to take care of these patients, and just let's just work together. It's a team approach, definitely.
Yeah, I'd agree. Miajenell?
It's to do the work. I'm just excited to do the work, excited about what Memphis is going to look like. And I mean, if we've done all this in 4 years, what it's going to look like in another 4 years. But yeah, you don't necessarily need all the things. Just start, start talking to one person that's pregnant that and tell them that it may be a different way to approach birth.
Yeah, start somewhere. I agree. And just do the work and be willing to be open to new things and new ideas, and really be willing to re-educate yourself. I think that's the key.
Well, I would like to thank you all the three of you so much for participating today. I hope that the attendees have felt how powerful the work is you're doing, and really kind of understand the scope and the breadth. And if you came to this webinar and didn't already believe in Black Girl Magic and you still don't believe now, there's nothing I can do for you. I would also say it is my great honor and privilege to be in active allyship with the three of you on a regular basis. I love burning stuff down, so if you need me to light a match, I'm happy to do it. You just let me know. Thank you all so much for joining us. Please share this webinar. It'll be on our Facebook, YouTube, on the socials. My little sister told me I've got to stop putting "the" in front of social media names. It makes me sound old, but thank you guys so much, and we will talk to you all very soon.
Bye.
Bye.